Stanford University.
Thank you very much, Phil, for that wonderful introduction. Can you hear me pretty well at the back there? I must say I'm actually slightly intimidated by being the first in this series of lectures because I've looked at the list and it's really quite remarkable what you're going to be hearing. But I must say I think I prefer to be the first. I've had the misfortune of always having very hard acts to follow, and I remember the last time this happened was at the University of Iowa. I was at a conference not on medicine but on the narrative voice. And the speaker before me happened to be the University of Iowa's professor of religion. And he was a rabbi. He stood about 6'6". He had a wonderful baritone voice. He had won every teaching award the University of Iowa had ever offered. And when he got to the podium, he had such presence that I thought the microphone would turn into a snake or the podium would catch fire. And he actually began with the amazing proposition that the narrative voice originated at the moment that God spoke to Moses on the mountain. And he held forth on that topic in the most erudite fashion for 1 hour, sat down to thunderous applause, a standing ovation, and then I was introduced. And I remember getting up there and saying that I knew nothing about what God had said to Moses on the mountain, but I'd heard this apocryphal story, which I'm about to repeat to you, about what Moses said to the restless masses below. Moses said, I have good news and I have bad news. The good news is that it's down to 10. The bad news is that adultery is still in there. I think that there is great irony in this title that I've picked, The Physician in Modern Society, because, ladies and gentlemen, I have never lived through an era more exciting than the last couple of years, both in terms of the tremendous technological advances that we're seeing, but also in terms of an important philosophical question about the role of the physician in modern society. And I'm going to try my best to give you my take on it, and it's very much a personal take. And I'm going to use this painting by Sir Luke Fields, a very famous painting that most of you have seen in some fashion or other. And 100 years ago or so, Mitchell Banks, a professor of anatomy, said something prophetic, because he said, a library of books written in our honor would not do what this picture has done and will do for the medical profession. Remember always to hold before you the ideal figure of Luke Fields' picture and be at once, this was an era when it was largely men, be at once gentlemen and gentle doctors. And I want to tell you a little bit about Luke Fields because I think it's germane to our discussion. Luke Fields was born around 1846. He grew up in Liverpool. His grandmother was an important social activist, and I think his grandmother gave him his wonderful social conscience. He went to London and was educated at the Royal Academy and became an artist and sought employment as such. And one of his first commissions was for a magazine called The Graphic. And they gave him free rein and asked him to just illustrate whatever caught his fancy. And he had been very struck one night when he was walking down a street in London. He saw people lined up waiting for tickets to get into the casualty ward or the police station to spend the night outside, away from the cold. And it was a scene that he could not erase. And so that became his first composition. He actually paid people to pose for him. And when this came out, it actually caught everyone's fancy. It was really quite a striking drawing for that time. It caught the fancy of someone by the name of Charles Dickens, who was looking for an illustrator for his new book, The Mystery of Evan Drood, which he never completed, by the way. And so he hired Luke Fields, and Luke Fields also got the commission to change this drawing into an oil painting, which he did. And when this painting was displayed at the Royal Gallery, they had to have barricades to prevent people from mobbing it. It had enormous appeal because for its time it was a very different kind of painting. And I just want to lead you through it. He now retitled it Applicants for Admission to a Casual Ward. And by the way, that word casual really means indigent. If you wondered about the origin of the casualty service or the casualty ward, as emergency rooms are called in Britain, for example, that refers to indigent care. And I think what's most striking about this painting is the way we as viewers are sort of forced into the painting because of that wall at the back that kind of foreshortens the aesthetic distance so that we cannot escape from this picture of misery. And there is no relief in the wall except where the policeman stands, where he's handing out tickets, and there are no more tickets. And the only figure that you see clearly is this woman who is somewhat well-to-do compared to the people out there, and a child is begging for money from her. This was a very, very important painting in Field's career, and it led to a commission from Henry Tate, a man who made his fortune in the sugar business in the Caribbean. How many of you have been in the Tate Gallery? A wonderful gallery where, by the way, this painting hangs. And Tate commissioned Fields to do a painting that he called an English painting of importance. And by the way, the word English in that context at that time meant something that was socially important. And Fields decided that he would set out as his ambition to put on record the status of the doctor in our time. And he was moved to do so because of a very significant event in Sir Luke Field's life. His son Philip, aged 9 years of age, died on Christmas Day in 1887. And it was obviously a huge blow to the family and to him. And yet he wanted to record not so much the death of his son, but the grace and the care which his son received from a Dr. Murray. And so when he finally set out to do the painting, as you can see in the bottom left, he constructed this replica of a fisherman's cottage, and he posed actors, and he set about doing this remarkable painting. And I want to sort of take you through this, if I may. As you can see, in the center is this child who really occupies our attention right away. And we don't know if this is a boy or a girl, but something in the posture of those hands suggests that she is mortally ill. She's quite ill. And you also have a sense that this is a makeshift bed, and the child normally sleeps on a pallet of straw on the back of the cottage somewhere. And the pictorial space is nicely divided between the doctor on one side, the professional world on this side, on the other side, the mother and father waiting anxiously. And the doctor's attentiveness to his patient is really quite striking. What is also striking is the absence of any of the instruments of medicine, so to speak. All you see there is the doctor and his attention. And when Sir Luke Fields was asked about this, because the moment is pregnant, what is going to happen next? Interestingly, he did not say, well, what's going to happen next is that the child is going to die. He said, this painting is all about light coming through the window, the break of dawn, and how hope springs eternal for all of us. He never mentioned his dying child. This painting became, not surprisingly, the most famous medical painting in the world for many, many reasons. I think it had great emotional appeal, but it also was at a time when people were very, very conscious of the latest painting. There's a couple of unusual things about the doctor that I'll point out to you. First of all, the doctor in that picture, and by the way, there were many physicians who, once they heard that Sir Luke Fields had this commission for this painting, who jockeyed to have him model them, because they thought that, and they knew that that would really help their practice enormously. Dr. Murray, the one who took care of Philip, declined to be a model for this, a humble man. And ultimately Fields used sort of a composite of many different people. But the doctor in this painting is in the role of a general practitioner. He's in a fisherman's cottage, but he's in the dress of a consultant. So for those of you who are finicky, this is really something that's a little strange about the painting. What's also strange is that this is a time of huge medical advances, ether anesthesia, surgery, and yet Fields choose to depict something much less dramatic than, say, Eakins' famous painting of the Gross Clinic that you see on the bottom right there. And as I mentioned, Fields' son dies, and yet the painting radiates hope. And the doctor doesn't carry a stethoscope, he doesn't carry a thermometer. And when Fields was asked about this, his feeling was that he wanted to depict the doctor in our time, and that had, as far as he was concerned, very little to do with instruments and the other accoutrements of the profession. The image became so popular that it was actually issued as postage stamps. In 1949, the United States made it into a postage stamp to commemorate the 100th anniversary of the American Medical Association. And the AMA used this figure and this painting in their campaign against socialized medicine. President Truman tried to bring about socialized medicine at that time, and the AMA, in the persona of Morris Fishbein, a very interesting character, mounted this huge campaign that effectively undid President Truman's efforts. And many of you of a certain age will remember this poster in your doctor's offices, will remember this being on calendars, and the caption was, "Keep politics out of this picture," or that the government is going to take the doctor out of this picture. A real misinformation campaign, alas. Whereas by contrast in Britain, this painting was used to celebrate the anniversary of the National Health Service, where National Health Service was adopted very, very early on to end the club wars. And I should explain what that was. In that painting in the cottage, the kind of doctor who would have taken care of that patient would have been a club doctor, meaning about 70 families in one area would get together and hire a physician and work that poor person to death. He was the club doctor, and he had to come anytime he was called, and if he didn't do that, then they would not renew his contract. It was a very unfair, difficult practice, and the National Health Service actually came about in large part to overcome the club wars, as they called it. There's been so much commentary on this painting. So many observers have had lots to say about it, and I like this that was said by my colleague Howard Brody, who runs the Humanities Center at Galveston. He felt that this painting was all about the fact that character and virtue are as important as knowledge and skills in describing the ideal family physician, and Howard Brody is a family physician. He felt that this painting conveyed the fact that medical practice is more the maintenance of a network of human relationships than it is the application of scientific knowledge. And I will tell you that my own take on it is quite different. When I present this to physicians, I often say, it's not about you. This painting is not about you. It's about you and I identifying ourselves with that child, with that patient. And when we're in that role of patient, this is the sort of physician we would want taking care of us, someone who gives us their undivided attention. So to me, this painting really recalls a line in the New Testament, "I was ill and you cared for me." This is the sort of care we want to see. This is how it expresses itself. And my great worry, I know that Phil and I share this worry with the tremendous advances that come with medicine. My great worry is that if Fields had to do this painting in this day and age, it might look something like this. And sometimes I think that if an anthropologist from Mars descended on our institutions and came to our hospital, they would make some very bizarre conclusions. They would conclude that the main business of my specialty, internal medicine, took place in a conference room somewhat removed from the patient. They would conclude that the virtual patient, the eye patient, was infinitely more important than the real patient. And they would also perhaps conclude that there was something toxic in the patient environment, so that physicians minimized their exposure as much as they could. And they would also conclude that the patient's personhood was relegated to the margins of our attention, and we were far more interested in their two-dimensional images on x-rays and whatnot than we were in who they actually were, which would probably be a fair take for an observer from Mars. I want to switch gears and tell you a little bit about my own humbling, if you will. As Phil mentioned, I trained in infectious disease in Boston and finally went to Johnson City, Tennessee, population 50,000, at a time when HIV was just appearing in Boston. I remember taking care of the first couple of young men coming to Boston City Hospital with bizarre infections, pneumocystis pneumonia and Mycobacterium avium infection, all of which we'd seen before, but always in the context of immune suppression or transplant. But these young men had no such explanation. And I remember how the numbers kept growing, and I also remember the fear and excitement of that era, because clearly this was something new, but it was also something that seemed ripe for science to have a major breakthrough. And indeed, while I was still in Boston, I picked up the Boston Globe one morning and read that Gallo and Montagnier had discovered the cause for this illness. And I felt, as did many of you, I suspect, that it was just around the corner that we'd have a cure. And in fact, when the ELISA test, the blood test, was developed a few weeks later, it became apparent that for every one young man we were taking care of in the hospital, we were perhaps dealing with 100 to 200 others out there carrying this virus, and the full implications became clear. But I was leaving Boston. I was going to Johnson City, Tennessee, population 50,000, a small medical school, and all the pundits said that I could expect to see maybe 1 or 2 infected patients every year or every other year. And when I first got there in 1985, that seemed possible. But very soon I saw my first patient, and then in a few months my second. And in about 3 years, I was following 100 people with HIV in a town of 50,000, 100-fold more than anyone would have predicted for that small town. And it was the most important lesson of my life. It was a very humbling moment. I remember thinking that I had gone into infectious disease because, to me, infectious disease was the one specialty in medicine that was all about cure. I mean, I looked at the cardiologists, putzing around with their roto-rooters, and the idea of infectious disease, that you could see someone with a fever from the Congo who had just flown in and had this hemorrhagic rash, and you made an astute diagnosis, and they rose like Lazarus. What irony that a fatal illness should land in the laps of people like me, caught up in what I call the conceit of cure. And there was a wonderful lesson that I think we all learned in the process. I began to feel that I could not offer much to my patients in the hospital. We had no drugs, we had none of the new cocktails that we now use. And out of frustration, I began to leave the threshold of the big medical industrial complexes we work in, and I began to go to patients' houses. And I did that out of, as I said, frustration. And when I landed there, in their homes, I realized that my visit had a profound effect on me, on them. It was just tremendous. The family welcomed me, and it seemed to make them feel really happy that I'd come. The patient felt that I had not abandoned them. After all, there I was. And it gave me a sense of purpose. And over the years, I've tried to define what that was all about. And I explained it to myself this way. I discovered in that moment the difference between healing and curing. And lest I become hokey, I want to explain this to you. I want to explain this to you in the way that I explain it to my students. I try and give them an analogy for them to understand the difference between healing and curing. And I say, imagine you go home from this lecture, and you go back to your homes, and you find that the door has been kicked open, the lock is splintered, and all your belongings are strewn around. Your money is gone, your jewelry is gone, television. To the students I say, God forbid your iPod has been taken. You will be devastated. And then if you imagine the police come by a couple of hours later and say, we found the person who did this, here is all your stuff back. At that moment you will be cured, but you will not be healed. Your sense of violation will be so strong that you might even move from that dwelling. And the point I make with them is that all illness has a physical component, and sometimes if we're lucky in medicine we can fix that. But all illness always has a sense of violation, a sense of why me? And with diseases like cancer and HIV, that sense of violation was huge. And so this was a tremendous learning moment for me as a physician, an understanding of what was truly important and what it was the horse and buggy doctor of 100 years ago or so was able to offer in the absence of all the therapy that we now have. Eric Castle has something to say about this. He says, as far as I can see, you can heal somebody, you can be complete about it, but I'm not convinced that you make a bit of difference in the bodily disease. I think he was referring to that. And Roy in The House of God says, I didn't give a damn about their diseases or cures. What they wanted was what anyone wanted, the hand in the hand, the sense that their doctor could care. And my mission with our students is to make sure that they appreciate this before they go into practice and have it arrive to them the hard way, instead that they be aware of this dichotomy. I think, and maybe you can correct me during our discussion, I think that patients often see us as inattentive, disease and tests procedure oriented. The caption there says, the tests have ruled out anything expensive, so I'm referring you to a doctor who specializes in cheap diseases. And I've been doing a lot of reading around this business of technology and where do we fit it in. And an interesting book that I've been looking at is this one by Postman, who says, technology begets more technology, and tech-driven policies and economics, and finally people who can neither function nor think beyond the limits of the machine. I've become a big fan of this particular individual, and if you are interested in extra reading, this is a great book that I submit to you as worthy of your consideration. David Orr has been a very interesting thinker, and this book is called The Nature of Design. He makes a distinction between what he calls slow knowledge and fast knowledge, and I've been trying to bring this back to my medical students. He says slow knowledge is all about resilience. It's about harmony, the preservation of long-standing patterns that gives our lives aesthetic, spiritual, and social meaning. Slow knowledge rests on these beliefs that wisdom, not cleverness, is the goal of learning, that the velocity of knowledge is inversely proportional to the acquisition of wisdom, that careless application of knowledge can destroy the conditions that permit knowledge to flourish, and that rising volume of knowledge cannot compensate for increasing errors caused by malfeasance and stupidity generated in part by inappropriate knowledge. And when I read this, I thought, I've never heard character referred to in any of our medical discussions. The good character of knowledge creators is relevant to the truth they intend to advance. This is not something we normally think about in medicine, but perhaps we should. I think T.S. Eliot had something very similar to say. T.S. Eliot said, where is the knowledge we have, where is the wisdom we have lost in knowledge? Where is the knowledge we have lost in information? So there are dangers to our great acquisition of knowledge if we don't apply it correctly and forget the human connection. So how do I try to convey to my students the care and the attentiveness that was conveyed in that wonderful painting by Fields? Peabody, many, many years ago, Sir Francis Peabody said, not Sir Francis, but Francis Peabody said, the secret of the care of the patient is in caring for the patient. And I think that's very true. Our attentive presence means everything. The careful examination by the history and physical, reflection on the problem, by having one physician play quarterback, by the maxim that no tests before a patient is interviewed and examined, by beginning to think how we could manage if tests, procedures, and care were rationed, and they soon will be, by celebrating wisdom over knowledge and slow knowledge over fast. Measure less, reflect more, perfect the life as well as the work. I want to wind down with one anecdote that has been terribly important to me. In Texas, before I moved here, I developed the reputation of being interested in people with chronic fatigue. You don't want to wish this on your worst enemy. This is not a depiction that in normal circumstances will be good for you, because these patients can be very, very difficult. And I don't quite know how it happened, but one patient led to another. And pretty soon I was seeing a steady stream of patients with chronic fatigue. And I realized very early on that I could not address their needs in one visit. A new patient visit, I could not do a history and a physical. I needed much more time than that. And so I hit on this method with my patients, which is I would give them the first visit just to tell me their story. And I would try not to interrupt them. The average physician, we are told, interrupts their patient in 19 seconds. And if I ever go to heaven, it'll be because I held my peace for 1 full hour while they told me their story, which was very important for them to do. I would then schedule the visit, the physical exam, for another occasion, a week or two from the first visit. And since I had a lot of time now to do the physical, I would do a very thorough physical. I like to think I do a very thorough physical anyway, but I did a very thorough physical on these patients, invoking every maneuver that I could think of to invoke. And a very interesting thing happened with one of the first patients, a very voluble patient who wanted to continue telling me the story in the second visit, became silenced in a sense by our ritual. And as I kept doing what I did, I had a feeling that I had slipped back into an ancient ritual, one in which she had a role and I had a role, and that the ritual was powerful. I could actually sense it. It was a very important moment for me. And when I was done with her, this is one of my first patients with chronic fatigue, she said to me, in awe, she said, "I have never been examined like this before." And when I then had her get dressed and come to my office, and I told her the same things that she had heard at the Mayo Clinic and the Scott and White or wherever else she had been, that this is not in your head, this is real. The good news is it's not cancer, it's not histoplasma, it's not coccidioidomycosis. The bad news is we don't know exactly what causes this, but here's what we should do. And I always felt that if they gave up the quest for the magic bullet, the magic doctor, or the magic test, it was because I had earned the right to tell them that by virtue of the ritual of the careful exam. And that is really, ladies and gentlemen, what I try to teach my students. I want to close with this quote from Yeats, which I think is sort of operative in our lives. Yeats says that the intellect of man is forced to choose perfection of the life or perfection of the work. And if it takes the second, must refuse a heavenly mansion raging in the dark. Sometimes I think that is the choice being faced by us in medicine. Our work is so seductive. Our work in this day and age is so technologically mind-boggling and brilliant that we sometimes forget the life. And I think one has to keep both of those together. I'm going to close by reading you one paragraph from something that is in your reading list. This has to do, I wrote this fairly recently and submitted it for your reading. I remember all those years of taking care of people with HIV. Phil recalls those days when we had really very little to offer, and I would go to the room and visit with the patient and examine them every time. That was my ritual. And I remember leaving the room feeling so inadequate, so unable to help them. And the next day I would come and we'd do it all over again. And I wanted to read this last paragraph to you, and I'll stop with that, and then we'll take your questions. And here it is. I recall one patient who was at that point no more than a skeleton encased in shrinking skin, unable to speak, his mouth crusted with candida that was resistant to the usual medications. When he saw me on what turned out to be his last hours on earth, his hands moved as in slow motion. And as I wondered what he was up to, his stick fingers made their way to his pajama shirt, fumbling with his buttons. I realized that he was wanting to expose his wicker basket chest to me. It was an offering, an invitation. I did not decline. I percussed, I palpated, I auscultated. I think he surely must have known by then that it was vital for me, just as it seemed necessary for him. Neither of us could skip this ritual, which had nothing to do with detecting rales in his lungs or finding the gallop rhythm of heart failure. No, this ritual was about the one message that physicians have needed to convey to their patients, although God knows of late in our hubris, we seem to have forgotten. We seem to have drifted away, as if with the explosion of knowledge, the whole human genome mapped at our feet, we are lulled into forgetting that this ritual is cathartic to the physician and necessary for the patient. Forgetting that this ritual has meaning and a singular message to convey to the patient. And the message which I didn't fully understand then, even as I delivered it, and which I understand better now, is this: I will always, always be there with you. I will see you through this. I will never abandon you. I will be with you through the end. Thank you so much. The question is about concierge practices and what the motivation is for them. I believe that most of us, when we are in training, our dream of what a practice will be like is really a concierge practice. And then the reality, I think, of what happens is the way reimbursements work is that you literally have to have a panel, if you're in private practice, of 2,000-3,000 patients, and you can't spend very much time with them in order to make the overhead. And there comes a point, I think, when many physicians are frustrated with that and change to a concierge practice, which gives them all kinds of time with the patient. So I don't think the motive is monetary. I really think that they do it with great thought and with some regret, because they are closing the door, in a sense, on many people. But what it does do is allows them to have the kind of time that they want to spend with patients. It's, this is really a manifestation of reimbursement. The sad fact is that a psychiatrist gets less for a 45-minute therapeutic visit with a patient than he or she gets for a 15-minute medication encounter. And so these perverse incentives out there make us often wind up practicing medicine that's not what we intended to practice in the first place. I don't know if you wanted to add to that.
I do want to, if I can. I agree with Dr. Verghese, but I want to also say that I hope we as a society don't move toward a concierge practice as is currently been established. I hope that principle becomes part of medicine writ large, because that is the kind of medicine that we wish to practice. This is one of the sad testaments of our lives. It's really the fact that medicine has moved from a profession of care into a business model. And it's not, in many ways, even a sustainable business model. And I think all of us, you have experienced this yourself. You go to see your physician, you're lucky if you get 10 or 15 minutes on a good day. The bonding and the kind of description that you articulated is very hard to establish. And because physicians in most practice settings are told volume is what counts, keep driving the volume, and what gets lost is the human connection. It saddens me that in the midst of all that we're debating in this country about healthcare reform, that kind of dialogue isn't really even part of the communications that we're having today.
Well, the question is about our approach to mental illness and the mental illness that accompanies serious physical illness. And I think that is sort of what I was getting at, in the sense that almost any illness has this accompaniment of mental anguish, and sometimes with trauma especially, it's huge. People can be incapacitated by a post-traumatic stress disorder. So we're all for it. The question is, how do you pay for it? And I think that very often people get acute care very effectively. We speak of the 45 million uninsured. If they had an emergency, they are really attended to. But what they don't get is the very thing that you're talking about, which is preventive care, maintenance care, the sorts of things that I think an advanced society should be able to offer all its citizens. So the question is the coping mechanisms that the physician has when caring for very ill patients. And actually Phil probably has the world's experience with that, dealing with very, very sick children with leukemia, and I'll ask him to address that. But let me just tell you that I think this is a very important issue. Our medical students, when they come to the wards for the first time, the kind of carnage that they see is really not something that they are prepared for. And it shocks them. And until just a little while ago, in the macho culture of most hospital training programs, you were not free to say how much it bothered you to see this sight. In fact, the macho culture encouraged you to sort of not focus on the emotional content of what you were seeing. And that becomes sort of a coping mechanism. And I've become very interested in the phenomenon of physician suicide and addiction. And in researching that for my second book, The Tennis Partner, by the way, if you didn't know this, the highest suicide rates in the country are amongst doctors, lawyers, and dentists. They're 20-fold higher than any other profession. The lawyer part we don't worry about. No, I'm just But I tell my medical students that every year it takes 2 complete classes of medical students, about twice the people in this auditorium, to replace the number of physicians who committed suicide that year. And the great majority of those are from intemperate use of drugs or overdose. And I've wrestled long and hard with what's the mechanism. And I think my thesis is this, it's completely unsubstantiated, is that when students arrive on the wards and see this things that they do see, if we don't have a healthy way for them to talk about it, and as I said, in the old days when we trained, there really wasn't a culture that allowed you to talk freely about this, people quickly learn to sort of shut out the emotional content of what they're seeing. And frankly, if someone's bleeding on the street, that's appropriate. You should focus on airway, breathing, circulation, and not be worrying about the family and the social situation. But the thing that doctors do, I think, eventually is as they learn to shut out the emotional content, they do it to themselves. And physicians are notorious for denying their own patienthood. And when they get ill themselves, they present with a symptom that with any other physician, any other patient, you might say, well, before we get to the symptom, tell me about your marriage and how much alcohol are you drinking and how much weed are you smoking and what else is going on? Are you sleeping well? With a fellow physician, we don't address that. And when I went to this one center called the Talbot Center, which at any one time has 80 physicians inpatient treatment for addiction, I remember a very distinguished orthopedic surgeon telling me that he went to a colleague for a trivial somatic symptom, which was in retrospect an expression of his angst. And he was prescribed Tylenol with codeine, not prescribed, given from the sample cupboard. And he said, when I took that first tablet, I felt this weight that had been on my chest for 23 years slide away. And it was a very important revelation to me that day that physicians don't take drugs to produce euphoria. They take drugs to relieve the dysphoria of their existence. And my mission as a teacher is to make sure that on my watch, if possible, that we don't have students become so disconnected from their emotional state that they hurt themselves. It's a difficult thing to do because the culture doesn't always encourage them to speak freely. But your question about very sick children, I could not take care of very sick kids with HIV. Thankfully, I had a pediatric colleague, and I always wondered how they did that. It was hard.
But just a couple of very quick comments. First, I think that to the points that you were making, I felt very fortunate when I was a medical student, and this speaks to the process of education, that you can learn and be taught sensitivity as part of medicine. So I was at a medical school where there was a lot of interaction between psychiatry and internal medicine. This was at the University of Rochester in New York, and the person who was the lead there was an individual who you may remember by the name of George Engel, who founded the field of what we now call the psychosocial and biological parts of medicine. And we were taught, literally, as young students, to learn how to listen. In fact, the important point was that when you're beginning your introduction with a new patient, it's imperative that you don't ask a lot of questions, that you ask just one. What brings you here today, or how are you? And that you then pause and allow the patient, just as you articulated, Abraham, to tell their story. Because you have that only one time to do that. After you've begun the quiz, you've contaminated the relationship and maybe suppressed the information. So that message has held me very well, I think, over the years, and is actually not only useful in the practice of medicine, but it's pretty useful in being a dean as well. And I would further say that to your comment about, and Ryan's question about the pain of dealing with sick children or sick adults facing illness. First of all, I think I would add that with a serious illness, no one is left untouched. Many patients, in my experience, get stronger as a consequence, but some break down. But no one is left untouched as a consequence. And physicians aren't left untouched either. And in fact, what we did in our program when I was in Bethesda is that we worked with psychiatrists who met with our trainees every week. And I would, when I was in training, and then subsequently our trainees would, in a group session, share their experiences, and an experienced psychiatrist would help us put them into context. And that too was very powerful because it gave permission to say how hard it was, how difficult it was, how you slammed the door because this was such a huge impact on you. And I think it creates in each of us a very different way of approaching practice of medicine. In my own case, I feel that it's very important to share the pain and the discomfort. I try very hard when I'm in the room with someone who's suffering to feel that suffering, not to sort of block it out. It does take a toll on you, I agree, but I think if you don't allow that to happen, you can't forge that important connection. And then you need to think about and construct ways of being able to process that when you're outside of that connection. And that takes tolls on all of us, just as you've articulated, on ourselves as individuals, on our families, in terms of how we communicate, because each of us needs not only the public interaction, but that private time to be able to deal and process with that.
Sure, I appreciate that comment, very, very thoughtful. So the question is, does that picture truly represent what we're dealing with now, and is that really germane to the practice? I would argue yes. I would say that the population of this country is aging rapidly. The great burden that we're dealing with day in and day out is chronic disease. And I find that the thing that young doctors are most uncomfortable with are diseases that have no epiphany, no dramatic resolution with the administration of antibiotics and so on. And what the patient needs, I think, when they come in and day out, or week in and week out with the same set of chronic conditions, they need that affirmation that they are still worthy of that kind of attentiveness. And they need the sense that you will be that constant, and your attention will not vary because they've become less than interesting at this point. So I find on the hospital wards, this is not a critique of the house staff, this is universal, that our house staff are very ready to label people with acronyms such as, when you come in with chest pain, you become a ROMI, which is a rule out myocardial infarction, and a couple of days later you become a MIRO, which is myocardial infarction ruled out, and we are very adept at labels and acute care, all the things that they could not do in that era. But I'm always interested when I sense a resistance to go into a room because, quotes, there's nothing we're going to do now. And I always think, well, that is the beginning of the very thing that we're going to do. And I actually see that picture to me as emblematic of that thing, which is to go in there and give them your undivided attention. Just because you can't cure it does not begin to mean that you have no role in there. In fact, I would argue that is when your role is most maximal. And I have one patient who comes to mind who I followed for a number of years, and from Texas she still comes to see me, has come at least once now. And I've often wondered, what is it that I offer her, since nothing about her illness is getting better, everything is progressing. But what I give her is my full attention, my validation that her illness is important. Just because it doesn't have a magic fix, it is still very important. And I've come to think of myself as almost her coach, encouraging her to hang in there, just as we all hang in there. And I think that's what that picture is about, is dawn breaking, hope coming. William Osler said, it is not for us to take hope away from the patient, hope that comes to us all. And I think that's true even when you have a chronic condition that cannot be cured. I hope that addresses your question, but your point's well taken. Thank you. So the question, if I can summarize it, is about primary care and the crisis of not having enough physicians to do the kind of thing that I'm describing. I think that's a very real concern, and I think it's one of the reasons that Phil wrote a very lovely editorial some weeks back in the LA Times, and I hope it becomes part of your package, because those of us who are in healthcare feel very strongly that reimbursement provides perverse incentives that take our students in different directions. Our students sometimes speak tongue-in-cheek, but not entirely, about the road to happiness. and the road is radiology, orthopedics, anesthesia, and dermatology. And it used to be that when Phil and I trained, the best and the brightest would often go into internal medicine and primary care and pediatrics, the very things that are not rewarding. And I don't blame them. They come out with so much debt that it's not illogical for them to think of how to pay that. So I think a crisis in healthcare, quite apart from the uninsured and so on, is how do we train more primary care physicians? And that alone, I think, should be a great incentive for restructuring payment. Right now, in America, I think we pay people to do things to patients as opposed to do things for patients. Procedures make money, and so we have a profusion of procedure-related places and things, short stay centers and this center and that center. How many of you have ever seen a freestanding geriatric center? We've all seen short stay surgery. There's a reason for that. There's no money in that, and I think that reimbursement has to change in order to change these strange incentives that make it hard to generate primary care physicians.
Yeah. I just would add one other comment to that. I think that part of it is just as you've heard, that we're also dealing with a different generation who has a different set of values. I mean, we grew up at a time with, a dedication to work. We recognize that we're dealing with different kinds of values in individuals. But I think, you may not know this, an average medical student graduating today has an indebtedness of $175,000, right? So that's how they start their life. And that's a pretty big pill to swallow, and it does influence what people decide to do. And then it's made worse by the subtle messages that are given. You talked about the language that we inappropriately use sometimes to describe patients in a dehumanizing way. Well, in our medical care system, primary care is often looked at as the, quote, lost leader. Lost leader. That's the message that gets conveyed. What does that mean? It means that the primary care physician doesn't make herself or himself enough to really compensate themselves, someone else to do that, the procedure-based individual. So if you're a student and you begin to hear that, it doesn't really inspire you to think that this is a pathway that makes a lot of sense. The other thing that I would say to your comment is I think we need as a nation to look more broadly at the healthcare providers. It's not just about doctors providing health care. There are wonderful nurse practitioners and nurse clinicians who can complement this work enormously and spread it into more directions. There's been a move over the last couple of years sponsored by the society that deals with medical schools and education to actually increase by 30% the number of physicians. I'm not sure that that's the right thing to do. And the reason is, unless we can guide where they go, they're going to continue to make exactly the same choices that they have up until now, which moves into areas where we already have a surplus. So we need to think more constructively about how to both train, educate, and distribute physicians and other providers in a more rational way. And that isn't easy to happen without a rational healthcare system.
I think one of the most wonderful movements that has happened in the last decade or so is the emergence of the hospice movement and palliative care. And the emergence of palliative care as a specialty, our best and brightest are often heading in that direction. And so I'm very encouraged, I think, that our students, like never before, get wonderful lessons on how to break bad news, how to deal with situations like that. They have both classes and hands-on sort of training. So I think we're doing a much better job than in my era of training. I think most of us learned on the job, which in retrospect was a terrible way to have to learn it. So at least on this campus, but I think also uniformly in America, medical students are getting that kind of training in a way that they never got before. I think that the question is about the last 6 months of life and how oftentimes a person will spend all their savings in that last 6 weeks sometimes of life. And I think you're very correct in the way you phrase that. Alan Garber, one of our professors here at the medical school, I think you're hearing from him this quarter. Alan Garber has a wonderful article a couple of months ago in the Annals of Medicine where he described our healthcare system as a menu without prices. It's like you go into a restaurant and you order filet mignon every time because you're not conscious of how much anything costs. I think that's true both on the doctor's end and on the patient's end to some degree. So the issue of how much is this going to cost if we prolong this ICU care doesn't really enter into the discussion very much. It's much more of a question of are we ready to give up or not. And I think that, as a society, we expect care, and I think we have every right to do that. We're very uncomfortable with any notion of ceasing care. I was at a meeting earlier today where someone mentioned that the American public has never met a test that they did not like or a procedure they did not like. And so, I think there's a great sense that, well, I don't want to miss something that might be helpful. And as a result, I can tell you our young trainees, our residents and interns, when you ask them, what is the single most important thing that frustrates you about your training, they will often say it's all the activity that we have to do around care that's clearly futile, but we haven't gotten everyone to come around to that. And in the days that it takes to get everyone to come around to that, thousands and thousands of dollars are being spent at that moment.
Can I just make that?
Please.
So I want to just also offer a comment on this because I think it really is a critical issue, and it's part of our culture. As we think about healthcare reform, one topic that's not made it to the agenda is our expectations in this country as individuals, and this is really a big part of it. Unfortunately, it's gotten reframed in a different way with the concept of death panels and the like, which is a very unfortunate way of addressing a critically important issue, which is what are the appropriate limits of care. And it's interesting to me as someone who's as Abraham has said, cared for children with chronic diseases over the years to think about that as different from as it applies to adults facing the terminal aspects of life. Because in pediatrics, I've watched children suffer enormously and watch their parents try and grapple and understand what the boundaries might be. And I fear that we have so conditioned ourselves to, quote, expect that we will do everything, that we've lost the sense of reality. My approach to medicine has always been to be as aggressive as one can be when there is an opportunity for survival in life, and to be equally aggressive, if you will, when there is none. Because I think that's a way of addressing an issue that unfortunately we have not as a nation been willing to accept or even think about. I will say it here because it may engender some discussion which is appropriate on this topic, that other nations have dealt with this. Perhaps the most poignantly is the Netherlands, where there has been a whole policy of, quote, euthanasia. And that engenders a lot of fear, doesn't it, when you hear the words? And yet, because of the policies and the approaches and the sensitivity and compassion that's been exercised, at least in that nation where the discourse has happened, it's not adversely impacted on the perception or the culture of individuals about the endpoints of life. Here it evokes fear, it evokes anxiety, and it lends itself to hyperbole in ways that don't allow us as a nation to really think seriously about a very important topic.
The question is about alternative forms of medicine, if I can summarize that. I think that it's very telling that patients are going in droves, I think, to acupuncturists, massage therapists, and so on. And the one thing that all these individuals have in common is, for the most part, they listen and they touch. And I suspect that if we in medicine were attentive and had the time to be attentive and believed in the ritual of examining them well, some of these things would be addressed. I am a person of science, and so it's difficult for me to not ask for the scientific method when trying to evaluate different therapies. And alternative medicine is something that I've really wrestled with. I never try and dissuade someone from taking something if they truly believe, but I always worry about harm. And a huge lobby sort of took all those drugs out from the purview of the FDA. And so as long as you have a drug that doesn't make any claim to cure, only to improve your prostate health and enhance your male vigor and promote the growth of your hair and etc., you can put anything in a pill and give it to the American public. And the huge lobby out there which is making a lot of money on this, fights any attempt to regulate that. So I'm completely for all forms of therapy that are holistic and helpful. I think couched in there, hidden in there, is a huge drug lobby that lobbies for drugs that are, at best, not very effective. Because if they were, as we study them, we find very few that are really holding up. But at worst, as has been shown recently, some of them are actually contaminated with things that you would not know about because there's no regulation. So this is not to disagree with you on anything that you said. I'm all for alternative forms of therapy, and especially with chronic illness, I think that we in Western medicine don't do a good job of making the patient feel better and move ahead. And all those modalities, I think, do a much better job of that. Well, osteopaths train with us. They're very much part of the Western medical establishment, even though they have this grounding in a different science. So actually, many of them that I know don't really do that much of that anymore. They're much more, very difficult to differentiate from us in what they do. But they do have a grounding that I, admire and wish I knew more about, but I'm really not qualified to speak of it. So as long as they, my biggest fear as a physician, my nightmare, which I'll share with you, is that you come to see me with something that is diagnosable and treatable and slips through my grasp because I wasn't thinking of the diagnostic imperative and I missed it. So I'm all for all the other modalities that make you feel better. I would want to be sure that we don't miss something that could affect you. And so I think a lot of medicine is practiced that way, with a view to, let's make sure you don't have this, you don't have that, you don't have this, which is, in a sense, it's appropriate. But what happens as a result is you often feel that you were marched through all these hoops, at the end of which, there was it was in the New York Times, there was a story of this guy who had a headache, went to see someone, they thought they auscultated something in his carotid, so he got an angiogram, and he finally came out of it with a bill of about $120,000, and it turned out that nothing was wrong. And that might be an instance where a careful history and 40 minutes of spending time might have saved a whole lot of money. I don't think that answers your question, but I respect that there are many ways of doing this. So the comment is about the novel The House of God. How many of you know the novel The House of God? It's an interesting novel. It really is. It's written by a friend of mine, Samuel Shem, and what I find very interesting is that if you go on Amazon, for example, and look at the comments about the novel, you'll find medical students who've stumbled onto it and see it as an instruction manual. And it was clearly meant to be, an allegory. It was meant to be, ironic. But I think it's important to point out that yes, many of the things that happen during training still can happen. In some ways, things are much better. We are now working with an 80-hour work rule limit, so we cannot have people work the kind of hours that you saw in the House of God. Our residents have to be sent out at a certain hour. The clock is always ticking. So I think it's made them healthier and more wholesome. It's raised a new problem, which is handoffs. So we have so many people coming and going that I have great fears about patients being handed off. And I sometimes worry that they don't get to see the whole course of the illness. There used to be a joke when I was in training, which I think is reflective of the machismo of that era, and the joke was, what is the disadvantage of every other night call? Which is what we did, is every other night call. Can you imagine that? My residents can't when I say that, by the way. And the question was, what's the disadvantage of every other night call? And the answer was, you miss half the interesting patients. And we are very far away from that. So I think we're a much more humane training program. We have lost something, we have new problems that have crept in because of that. But I don't think that the dehumanization that one saw in that book, again, largely amplified and ironically delivered, I don't think we see those extremes now. We're much more conscious about that. Yes?
Could you talk about the impetus for writing the books that you've written and the novel that you've written?
So the question is the impetus for writing the books that I've written and the novel I've written. The first book came out of the great desire to capture the story of what happened in that small town. I mentioned that there were 100-fold more people with HIV in that small population than anyone would have expected. And I actually wrote a scientific paper one day that explained that. And I One day I actually understood the paradigm of why I had so many patients with HIV. It turned out that this was a phenomenon of migration. A young man grows up in a small town, leaves for all the reasons that you and I leave small towns, jobs, education, but in their case they were leaving because they were gay. And they left as part of the general exodus and went to the big cities and lived there for many years, and at some point they were infected with HIV. And then they started coming back to their rural homes, either because they were sick or because they were well but hoped to escape this plague that had killed everybody else in their neighborhood. And there I was at the tail end of that migration. And I wrote a scientific paper, much cited, describing this, because I thought it was important to point out this was happening in all rural communities. But even as I wrote the paper, I had the strong sense that the precise language of science didn't begin to capture the grief of these families, didn't begin to capture the tragic nature of the voyage, didn't begin to capture my own heartache at seeing this happen again and again. And that was the moment that my great desire to write came about. And I thought I would tell the story in fiction. I'd always thought that fiction would be the way I did it. And I actually had a short story in the New Yorker, a very dark AIDS story, fictional story. And that, when the editors found out about my background, they invited me to write a long non-fiction piece, which wound up being my first book. But I've always had a great conviction that fiction is terribly important. Dorothy Allison, the novelist, says that fiction is the great lie that tells the truth about how the world lives. And we use fiction with our medical students. If I want to have my medical student truly understand what it's like to be at the end of life, dying, I can point them to a hospice textbook, or we can read together The Death of Ivan Ilyich by Tolstoy. Wonderful story, a brilliant story. Or if they want to understand child abuse, really understand it, I point them to Bastard Out of Carolina by Dorothy Allison. So I think literature is a wonderful complementary way to illustrate the great truths in our lives, and that was really my impetus to write fiction, was to tell a kind of truth, if you will. I think it's the question is about the internet patient, as you put it. The internet has given access to all kinds of medical information, and actually, for the most part, I think it's been good. I think people are informed about their diseases and about their medications. It depends on certain patients. Some patients, I think, are not served well by reading all the side effects of the drugs you prescribe. And I have some stoic patients who don't want to know, and I think that's healthy in its own way. So, you can't fight it. There it is. But there's a lot of misinformation out there, unfortunately. There's a lot of sites that, my own father, I'm always engaging in these debates with him, and he's gotten his information from the internet and quotes it to me, and I try to tell him, well, it's not a peer-reviewed controlled study, and it just doesn't work. I think Phil could speak to the talking to each other part. I do think that the crisis in nursing is something that we are witnessing too. There's a lot of people on the wards who look like nurses, they're dressed like nurses, but the actual RN who's in charge is stretched very, very thin. We're using a lot more nursing assistants, and people often will say, at least in Texas, this was a truism, that the best nursing care was in the ICU, because you had really skilled nurses there who were very tuned to critical disease. But on the floors, because of nursing shortages, I think nurses are spread very, very thin. I think that nurses and physicians can do a lot more together, given that we train in the same environment. And I've always bemoaned the fact that we don't do as many things together as we should. I don't know if Phil would comment on that.
I think it's a very, very important question, and I think nurses also, in many ways, suffer from the same problems. The amount of paperwork, the amount of computer time. If you ask many of them, that separates them from the very thing that they care deeply about. There are different choices that we make in terms of going into nursing or into becoming a physician, and I think one of the great values is that patient contact, and in most of our institutions that is altered. I would say that the team-based concept, which is what you're alluding to, I think is very much part of our future solution. That is the only way we're going to really be able to have a broad enough, sophisticated enough workforce to really address these issues. And that does mean getting out of our silos. The physicians try to control their space, the nurses are trying to control theirs. There's a lot of don't cross this line. Even among physicians, there's constant tension about who controls a technology or a technique. Things that once belonged to the surgeon now belong to the radiologist. And a lot of this, unfortunately, speaking bluntly but honestly, is driven by financial motivations to some subtle undercurrent degree. And I think until we can reconcile that, we'll lose really the focus on what's really important. How do we provide the best acute and then chronic care to individuals? And that will be by a team-based process.
I think that's a fair statement. The question is 90% of illness is caused by stress. That might be a little more than I would be willing to accept, 90%, but I do think that stress certainly complicates illness, it certainly brings on illness, and we don't do a very good job of addressing that, primarily because we don't really have good continuing relationships with a huge segment of our population. 45 million Americans get their care only in emergent situations, and so I could not fault you for saying that we don't address stress well. I think that's true. As a population, we don't do that very well. The question is about medical ethics and what role they play. Actually, at Stanford, we have a very vibrant ethics program, and they're very involved in the ICU. They round once a week there, and they do get involved in just those situations where the wife says the husband didn't want anything more done, the daughter says no, he wants everything done, and there's a lot of conflict, and that they get an ethics consult, and their decision is binding. And so we are using them all the time. The ethics of the healthcare debate is actually a very interesting question, because the ethics of distribution of resources, the ethics of containing your expenditure so that you can benefit the greater good, if you will. I think that that's very much at the heart of this debate. And the whole notion of greater good versus the best treatment for the individual is really what we're talking about. So ethics is really front and center. I think it's just couched in terms like death squads and so on, but it really is an ethical discussion that we're talking about.
Although it is a movie of a lot of anecdotes, Michael Moore's movie, if you saw it, called Sicko, ended with a phrase to me that resonates very closely with what Abraham spoke, and he said, one of the things we need to reconcile is whether we're a nation of we's or me's. And I think that cuts right to the heart of that.
So the question is, how do the medical students respond to the iPatient and the computerized medical record? I can tell you that when I take them on bedside rounds and we go around and examine patients, and I'm able to show them fairly simple, straightforward things that the body is willing to reveal to us should we be looking, they absolutely love it. And I'll often hear them say, this is why I came to medical school. And I imagined that it would always be like this. And they are disappointed to find that so much of the activity takes place around the computer. So I think they are my strongest allies in getting them out of the bunker, if you will, and getting them out to the wards. They truly enjoy that, and they just needed some faith to see that it can work and that it is rewarding. It's places it's very accurate. Some places, some diseases are diagnosed entirely by the physical exam. Parkinson's disease, Bell's palsy. There are no tests for this. You have to examine the patient and come up with these kinds of conclusions. So the question is about medical errors and duty hours. So, medical errors are something that I think we've become very conscious of, and the electronic medical record, with all its disadvantages, has huge advantages in terms of preventing certain kinds of errors, and that's been a great boon. I don't think anybody works 40 hours continuously anymore at all. So, after the Libby Zion case in New York, there's been a huge change in the way we train residents, and some talk recently of shortening the hours even more. And I actually think that the duty hour problem is something that was just imposed on us. It has never been examined systematically to see if it really translated into more patient safety. My own bias is that all these handoffs are potentially more dangerous, and we just simply have not studied them adequately. So it's a double-edged sword. You cut down duty hours, you increase handoffs, but you do have a more fresh and sane residents. There's I think it's a 60-hour work rule, I believe. It's not 80 hour. Right now it's an 80-hour work rule.
And there's a limit on the amount of time in a block. I think you're asking about, just to be clear, you're asking about whether or not we help patients to be compliant with the therapies that are being administered. Is that what you're asking?
Yeah, address it with that.
Yeah. Yeah. It's a tremendous, this is also a big historical issue. There's been problems with compliance for the generations, if you will. I mean, the classic studies that go back to strep throat and penicillin shows that, you know, if you prescribe 10 days, most patients take 3 or 4 and they're feeling better and they stop. And I do think it's a matter of both education, discussion, follow-up, and compliance, believe it or not, has effects in and of itself. Because it carries with it a placebo effect that has an impact as well. So it's an interesting concept. Well, let me thank again Dr. Verghese for wonderful. I hope from your applause that you did enjoy this session tonight. Next week, as promised, we're going to move from these important social and ethereal values right down to the molecule. We have one book. If you haven't gotten it already, you may want to look at it. It's actually pretty good. It's called The Body, and how it grows, how it works, and how it keeps healthy. On the website are the advanced readings for the next lecture. We'll provide additional readings for you as well as we go along, but hopefully you'll find the presentations to be quite compelling in their own right. So thanks for being here tonight. Look forward to seeing you next week.
For more, please visit us at stanford.edu.